Good morning, everyone. I'm Dr. Sushmita, consultant liver transplant anesthetist, Star Hospital. So my case is a 48-year-old male presented to our hospital with jaundice of 2 months and ascites of 1 month. He was diagnosed with chronic liver disease, ethanol-related, and was on medical management. He was abstinence for 3 months, and he had past history of HE grade 1 to 2, AKI grade 1, which was resolved, and he had history of steroid usage for alcoholic hepatitis. And is a known case of diabetic type 2 mellitus and on oral hypoglycemic agents. On examination, he had icterus and bilateral pitting pedal edema, grossly distended tense ascites, and right basal entry was decreased. On labs, the platelets were 38,000, INR was 2.92, total bilirubin of 15.4, albumin of 1.9, and sodium of 125. The MEL score was 34. The diagnosis was acute and chronic liver failure. He had portal hypertension and was a non-bleeder with small esophageal varices, alcoholic hepatitis with underlying alcoholic liver disease, and organ dysfunction being AKI grade 1, which was resolved. The need for liver transplantation was explained. On routine workup, we found that CMV IgG was positive and IgM was also positive. So my first question to Sachin sir, so what is the significance of CMV IgM positive?
CMV IgG positive along with IgM means it has been little bit old infection. It means it has been more than a duration, and in such cases we need to see the viral load, and probability of going ahead with this status will be a better. Only issue will be when if it is only IgM positive and IgG is negative, and if there is any associated transaminitis along with it, then it will have a significance.
Okay, sir. So we had done CMV DNA qualitative PCR, and we found that the viral load was 7,700 per ml. So my next question is to Sukanya ma'am, should we treat this, how do we proceed?
So Dr. Sushmita, I'd like to know, did the patient have any symptoms, any clinical
No ma'am, patient was completely asymptomatic.
So I think CMV PCR below 10,000, 1,000 to 10,000 is a very uncertain range. You cannot, in the presence of a proper clinical scenario or symptoms, you should definitely treat. Otherwise, the guidelines are very vague on treating somebody with a viral load less than 10,000. So I would probably look for, other evidence, say something on the lungs, on the CT, HRCT chest, something which shows some subtle infection or something, and only then think of it treating pre-transplant. Post-transplant, definitely one would have to treat prophylactic.
My next question is to Sharad Putta sir. Sir, how do we monitor the viral load and how long do we have to wait before transplant? Like what are the endpoints before taking up a transplant?
Yeah, I think just a bit of background. So this is a youngish patient, around 40.
So 48.
Yeah, 40, and so he's had steroids.
Yes, sir.
So that's the background, and so it is unusual to have a CMV infection pre-transplant. To come across a CMV infection is a little unusual, but now that you have these copies, but there's no evidence of any infection, right? No retinitis,
yes, sir. No
pneumonitis.
retinitis.
So there's no end organ involvement as such. So we're just treating a viral load.
Yes, sir.
I think couple of weeks and then you check your DNA again. That should come down to undetectable levels because the levels are not very high. And if there's no evidence of any end organ infection as such, you could possibly wait for 2 to 4 weeks and then go ahead with your transplant. But again, how long you wait is determined by the patient's condition. We're not going to just wait because one number is high, because you're anyway going to go through the transplant with the antivirals on board.
Thank you. So we treated the patient with tab, valgan, cyclovir, 900 mg BD pre-transplant for 3 weeks, and then repeated the CMV DNA qualitative PCR, which showed the viral load was not detected. And we found, we had done a CT abdomen and with lower chest sections, and we found these lesions. So Kanya ma'am, what do you think is the finding of the CT? And
yeah, though this is only the lower cuts, but what we can see, what we can see there is actually cavitating nodules. At least 2 we are able to see, 3 we are able to see. One is in the perihilar area, and remaining in the, is probably in the lower lobes, lower segments. We see 3 or 4 we can see, even one on the right side also, right lung also we can see. So in a differential diagnosis in a patient with a chronic liver disease who's immunocompromised, has received steroids in the past for this thing, and he has a CMV infection. So these are all risk factors for a fungal infection. So first possibility will be a fungal infection in the form of invasive pulmonary aspergillosis. Other differential diagnosis for such a cavitating nodules, multiple bilaterally seen, will be septic emboli, but they are more predominant in the basis and more towards the periphery. So we definitely need to do blood cultures and rule out endocarditis in such patients. So third thing will be, of course, tuberculosis in our country, but one thing odd for tuberculosis is, again, the lower lobes are predominantly seen here, at least I can't see the upper cuts. And second thing is the intervening parenchyma is normal, which is usually not the case in case of tuberculosis. You'll have more coalescent lesions with the consolidations between. Other things, of course, in a non-CLD patient would be vasculitis conditions, like anchor vasculitis will be other differential for cavitating nodules. But first, high on the list will be invasive aspergillosis because of the history of CMV, steroid use, CLD, which are all risk factors for invasive aspergillosis.
Dr. Chanda, may I ask, do you think that is a fungal ball?
It's not a fungal ball. It's
In
a
the cavity?
No, it's not a fungal ball. That's not no. It is mainly a cavitating nodule, which because of the central necrosis, the necrotic element falls towards one side. So you see a crescent sign. It's typically a crescent sign, but it's not a fungal ball. Fungal ball is in the previous cavity you have a fungal colonization. That's called a fungal ball. This is not a fungal ball. It's the invasive aspergillosis. Typically it presents like this with a crescent sign.
And how do we have to evaluate it, ma'am? Like, how do we go next? How do we proceed?
Yeah, so there are different criteria. Actually, for the routine criteria which are given by the EORTC or mycosis study group of the European Society, they basically give the criteria for the neutropenic patients, like post-bone marrow transplant or post-immunosuppression patients. But now there are criteria for patients who are in the ICU and who have other non-hematological or non-malignancy related risk factors like CLD and steroid use and COPD patients. So we have what's called the Aspergillus ICU criteria, which take into consideration 4 factors. First is, of course, the clinical factors, that is the signs and symptoms suggestive of a respiratory infection, where there is no response to after 3-4 days of antibiotics, the patient continues to have hemoptysis, cough, expectation, breathlessness. Second is the radiological criteria, where you have typical features suggestive of a aspergillosis infection. Third will be the mycological criteria, where you have either a lower respiratory tract cultures positive for aspergillus, or you have the biomarkers positive in the form of galactomannan. And the fourth, you either can have host factors or you can have a semi-quantitative cultures of this thing. So the Aspergillus ICU criteria are more used for this group of non-neutropenic patients. And non-neutropenic patients, usually serum galactomannan is not very sensitive because the neutrophils in the blood will eat away the galactomannan. So the sensitivity comes down. So the cutoff in the serum galactomannan for non-neutropenic patients, they have decreased it to 0.5. So any serum galactomannan more than 0.5 is considered to be significant, that increases sensitivity. Whereas the ball galactomannan is much more sensitive, picks up, and the sensitivity is around 80 to 80% with a specificity of more than 90%. So we should ideally, this patient should undergo a serum galactomannan test and also bronchoscopy with a ball from that area, from the segment, and send it for appropriate investigation, including the fungal stain, fungal cultures, and also because in our country we need to know tuberculosis, so AFB stain and the TB PCR or a gene expert, and of course ball galactomannan. So this is what I would do for this patient. Yeah.
Yes, ma'am. So we have done, we had proceeded with bronchoscopy as you had said. We had also sent serum and ball galactomannan test, and ball, AFB, fungal, gram stain, biopsy, TB PCR and cultures, everything have come negative. Pine viral PCR had also come negative. The ball galactomannan was weakly positive, but the serum galactomannan initially was 0.83. After 48 hours we had repeated and it was quite significant, it was 1.74. You have already answered this question, so serum galactomannan positivity. And what is the choice of antifungal agents in child C patients, ma'am?
So I think the drug of choice otherwise would be, last one indication is for voriconazole. Is a drug of choice for azole, is a drug of choice for invasive aspergillosis. But because it's child C, I would go for probably isavuconazole, which has a lesser hepatotoxicity in this patient. So isavuconazole will be the drug of choice in this patient, child C. If we cannot still use isavuconazole, it still has around 10% chance of hepatotoxicity, even in isavuconazole. So maybe second drug of choice would be liposomal amphotericin.
And what are the treatment endpoints? Is this clinical recovery or biochemical or radiological resolution?
I think it's a combination of all. So he hadn't had much clinical features.
Yes,
So here we can do a serum galactomannan, serial galactomannan or ball galactomannan. If it's decreasing in amount, it indicates that the patient is improving. Second, the radiological improvement. So CT improvement is important also, or radiological improvement. So probably biochemical and radiological improvement is what I would say.
So with strong clinical suspicion for a fungal infection, we get started tablet isavuconazole 200 mg TID for 2 days followed by OD. It was given 2 weeks prior to transplant and there was clinical improvement. During the course, patient had spontaneous pneumothorax for which ICD was placed and managed before surgery. Condition at transplant, he had improved quite well. The platelets had improved, INR had decreased, bilirubin had decreased and sodium had improved. So MELT had decreased from 34 to 28. So Sachin sir, is there any role of change of antifungal agents recommended preoperatively?
As this patient has responded, probably no. But just before a day of surgery, we will shift to amphotericin and continue in the post-operative period.
Okay. We had added injection amphotericin B from day 0 of transplant and continued for 5 days along with tablet isavuconazole 200 mg OD for 10 weeks in total. Patient was stable and was doing well post-op. This is his post-op labs, which shows platelets have improved, bilirubin had decreased and albumin has improved. And there was complete radiological resolution, which was taken 8 weeks after transplant. So my summary is active CMV infections present preoperatively should be treated. Preoperative fungal infections in CLD patients have very high mortalities. So high index of suspicion and prompt treatment is necessary to optimize patient overall outcomes. Thank you.
So I think Dr. Chandana has made some very important points in her narration of the CMV viremia. So pretty much as you see in the post-transplant period, when you are seeing an odd organism having grown, you should always look for the other members of in the hooligan group. So these are the MDR bugs, the CMV, the invasive fungal infection. So your patient has the right phenotype for developing an IFI. And it is well known, as it happens in the post-transplant period, that when you find a particular bug, in this case a virus, look for the others. Maybe to make the narrative more audience friendly, you made the CMV DNA narrative first, followed by the CT scan. But obviously the CT scan probably would have made this patient far more symptomatic. So the same thing holds for the post-transplant period also. So if you are seeing, say, an IFI, always look for the CMV. And we should all remember that CMV drug resistance is also on the rise. So we might think that valganciclovir always comes to a rescue, but in published literature from other SOTs actually says something to the contrary.
Thank you, sir.